Hello and welcome to this 30-minute seminar. We are going to discuss a huge topic which has very important clinical implications because that's what we deal every day, and it's management options for dogs and cats in congestive heart failure. So I try to keep it very simple, very practical. Let's see. Now, when we talk about congestive heart failure, we need first to define what that is. And let's start by saying that heart failure is a clinical syndrome. And because it's a clinical syndrome, we need clinical and diagnostic findings to say that that heart is failing. And what we mean by failing is that the heart isn't able to eject blood or to receive blood. And sometimes we refer to these two components as forward and backward failure. So forward failure is actually the inability of the heart to pump blood into the aorta and therefore the systemic circulation. And then backward heart failure is the increased hydrostatic pressure causing pulmonary edema, for example. We know that these two components, although we can just divide them, they can and probably are in most of our patients present at the same time. So it's just a dichotomic differentiation, but that doesn't clinically mean much unless we talk about pathophysiology and treatment, and I'll just briefly discuss that later on. What we mean by congestive heart failure is still a clinical syndrome, but is associated, we have heart failure and we have an associated water and sodium retention. And the typical, left-sided congestive heart failure is associated with pulmonary edema, and in cats also pleural effusion. Right-sided congestive heart failure is associated most commonly with ascites, pleural effusion, and in some dogs, subcutaneous edema, so fluid accumulation also in the subcutaneous compartment. And then we have those dogs and cats that may present with biventricular failure, so right and left-sided congestive heart failure, whereby we have pulmonary edema, pleural effusion, but also ascites. When we need to diagnose congestive heart failure, we need to keep in mind that it is a clinical syndrome. Therefore, we need clinical correlation. Why? Because we need clinical findings that tell us, well, these dogs or cats may have congestive heart failure, and then we need diagnostic findings that, further confirms our initial clinical suspicion. But it's made by these two components at the same time. We can't have congestive heart failure without diagnostic findings, but at the same time, we can't have congestive heart failure without, a dyspneic cat or a dog, okay, if that makes sense. So clinical correlation is important. And what are the clinical findings compatible with CHF? There is a long list, but if we think about left-sided congestive heart failure, I think the most important findings are those related to respiratory distress. So we have a patient that may have an increase in resting respiratory rate. It may be dyspneic or orthopneic, and that is indicating severe respiratory distress. We may see an increase in the coughing reported by owners, but we have to be careful because the cough per se is not telling us that the patient has congestive heart failure. To be in left-sided congestive heart failure, we need an increase in resting respiratory rate. And that is very important because we would wrongly treat our patient for congestive heart failure if they are coughing dogs and they might just have cardiac enlargement causing the cough. But it is indeed true that when they are in congestive heart failure, the clients do seem to notice an increase in the cough at home. And so this needs to be, further investigated, and that's why diagnostic findings are so important. We may have owners reporting of decreased activity levels, so exercise intolerance. They may be syncopal, they may show more generic clinical signs such as lethargy or decreased appetite. Let's move on to the diagnostic findings compatible with congestive heart failure. And the first diagnostic finding is our physical examination. And we need to find something that tells us that our patient, or that increases our level of suspicion of congestive heart failure. So we need to hear crackles or decreased lung sounds if we have fusions. Crackles sometimes can be difficult to, auscultate. But if we also hear a gallop rhythm, a tachycardic patient, cats can be bradycardic, but those, cats are always a little bit of the aliens in the group. But most of the dogs in congestive heart failure need to be tachycardic unless they have some AV blocks or additional findings. They may show jugular distension, they may have weak or irregular pulses, and if they have ascites, they may have a positive fluid wave. And then we have our actual, additional diagnostics in terms of imaging. And we can choose between thoracic radiographs if the patient is stable enough, or we have the ability in most cases now to do a quick focused ultrasound. And here is a little bit of, findings that we can see. I think the most important thing is we need to find both signs of heart disease that would justify the clinical signs that we are, seeing in our patient, but also we need to find also some pulmonary, if we're thinking about left-sided heart disease, left-sided congestive heart failure, or we need to find pleural, abdominal effusions. We need to find something that would justify the clinical signs and a concurrent cardiac changes that would justify that the two are related, because of course we can find a dog with, for example, respiratory distress that has other issues going on and has mitral valve disease, but the heart is small or the left atrium is not big. I think that is an additional important thing to correlate these two findings rather than say, oh, it must be this way. Okay. If we think about the pathophysiology of congestive heart failure, we are opening, a big topic. I've decided to make it very, very simple and very, very clinically oriented. So it's not expected to talk, we are not expected to talk in depth about this, but it's just, a nice summary of what is expected to happen if we have a patient going into heart failure, possibly congestive heart failure, associated or not with myocardial failure, so the inability of the heart to contract properly, which is found in most cases of congestive heart failure, but is not paramount to be there, right? So if we have a heart disease leading to heart failure, we will have a decrease in cardiac output. This will lead to a decrease in blood pressure, which will then activate our neurohormonal system. And there are different of them. the RAS system, so the renin-angiotensin-aldosterone system, the sympathetic nervous system, and other less known systems such as the vasopressins or the endothelin systems, but they are also important. They all work together. What's their aim? Their aim is to increase our heart rate and to increase sodium and therefore water retention. This arm of congestive heart failure can be referred to as the forward failure arm, right? Because we have a decrease in the cardiac output, so we have an inability to eject properly blood. And all these changes are secondary to this primary issue. But we also have something else going on in most of our patients. And as I said, most of the time, they're all together. They're not that much separate one to each other. So we have also an increase in hydrostatic pressure because the heart isn't able to, eject properly the blood. And so we may have that increase either on the left side or the right side. But in both situations, we have a decrease in capillary filtration. So the body tries to, decrease pressure, increase the filtration, but it isn't able to do that. And therefore we have edema and or fluid buildup, which could be pleural or abdominal. And that can be referred to the backward failure arm of congestive heart failure. But they are related, as we were saying, because if I have sodium and water retention, that will as well increase our edema and fluid buildup, because that will also increase our hydrostatic pressure. So in the end, what can happen is a vicious cycle. And this vicious cycle is in as much as these mechanisms of trying to cope with a low blood pressure, decreased cardiac output, and hydrostatic pressure were built for the acute phase. In the long term, they can cause maladaptive responses, cardiac injury, and then another cycle of worsening heart failure and back again, worsening all these things. So it becomes a vicious cycle. So the question is, okay, we know that this is a very simplified version of congestive heart failure. What can we target as clinicians to try to improve our patients' clinical signs and quality of life? First of all, pretty obvious, we need to tackle edema or sodium and water retention, more broadly speaking. So we need to target with diuretics. We can try to help this poor heart that is probably not working very well with inotropic support. We can also help with blood pressure, trying to adjust pressures in the heart and in the body. And we can then help neurohormonal activation by trying to adjust the bad guys and favor the good guys in all these systems. When we think about CHF though, not all CHF cases are the same, and I think we pretty much know that in clinical practice. We may have very severe acute CHF, and then we have those very mild ones that of course may require a different approach. So here is an example. We have a 5-year-old Dobby with these radiographs taken in emergency, so you can see it's basically cut because our clinicians were just like, right, we need to get a quick radiographs because they deemed the patient was stable enough to do a right lateral radiograph. This dog had a persistent cough over weeks, and then over the last few hours started to develop tachypnea, and a blood-tinged fluid came out of the nose. So it was pretty a severe thoracic radiographs. We can see that there is cardiomegaly, there is, it's a Dobby, so we wouldn't expect big hearts, even if they are. And we can see that there is a severe diffuse interstitial velar pattern. throughout the heart, throughout the lungs, throughout the lung fields. And this dog shouldn't be left, for home management of congestive heart failure. In fact, this doggy also was receiving CPAP, and I'm going to tell you very briefly about that later on. But you see 2 syringe pumps for inotropic support, diuretic support, and ECG monitoring, because we know doggies can do very bad things in terms of heart rhythms. Here we have on the other spectrum a cat that came up to us for a wellness check. The owner didn't notice anything in particular. We took radiographs, and you can see that the heart is big, and it's pretty much more obvious on the dorsoventral view. But then on the echo, we see B-lines, and then yes, this cat was in congestive heart failure. I'm not showing the echo picture of how bad the heart was, but I can tell you it was pretty an advanced cardiomyopathy, an HCM phenotype. But this cat was stable, was only mildly showing congestive heart failure on radiographs, but clinically was okay. So because of the client was also a reasonable person and very pragmatic and compliant, we decided to give it a go with home management. And I think that can be done as long as the client is aware of what to look for, and I'm going to discuss that very briefly later on, and you keep very close contact and close monitoring with the client and the cat, because that is possible above all if it's a very mild CHF. If it's a very acute and severe, it's probably not ideal. But one of the most important thing is we need to be very careful, because some of these congestive heart failure patients are very fragile. And so patient handling and safety comes first before diagnostic imaging is performed. I showed you a pic of a doggy that was pretty severe in his acute congestive heart failure. And our clinicians opted for thoracic radiographs only after they decided to stabilize. The dog received Ferozamide and was sedated. They very quickly took one thoracic radiograph, and they didn't repeat the radiograph, as you saw, because of the severity of what they found. I think that is enough if we need an additional proof, but as I said, it's a clinical syndrome. We need to put all the pieces of the puzzle together. And so, for example, this is an example of a severely dyspneic cat that came to us, and I wouldn't try to image this cat. I think we visualized that he was severely distressed, he needed sedation and oxygen and low stress, because these are the patients that can crash. After butorphanol and oxygen and sometimes to rest, you see that there is still some abdominal effort, but he's much better than before, and therefore you can very gently start all your investigations, putting an IV catheter on, for safety reasons, and then start all your investigations if you can. And as I said, a focused ultrasound in these situations is much more important than getting all the pics that you might or may not require for your diagnosis. So if we start thinking about the management in a cat or a dog with acute severe congestive heart failure, we need to lower the stress levels. We need to sedate our patients. The sedation can be variable depending also on the status of the patients, on the anxiety levels of our patients. Some may not need it, some others may need a low dose, some others may need a top-up. So you can always start with a low dose and then increase if needed. If you have an IV placed, that is great. If you need sedation for an IV placement, then you can start giving it IM. Butorphanol is probably the drug of choice. If you know, for example, that you have a cat that is very stressed at home and it's safe, it is safe to give gabapentin or trazodone at home before coming to the clinic, those have no or limited hemodynamic effects. So that can be something you can consider if you already know your patient. If you don't know him, then they come in, you assess them. If needed, you sedate them straight away. We had, for example, a case whereby the dog did well, responded to CHF, but was very stressed in the hospital. We needed, of course, to finish CHF treatment. If that is an option, you can consider trazodone at that stage, but you need to be sure that they can swallow and that they are stable, because we don't want to increase stress level by giving sedation, because that would be a contraindication, isn't it, or a bit of a not probably ideal. Oxygen is always a great treatment option. It's cheap. There are not side effects in actual facts. It's helpful to stabilize patients. If you have oxygen kennels, those are great, mostly for cats or for small dogs that might be a little bit more anxious, because they also act as noise reduction cages, and it's a safe environment. The downside of this is sometimes if you open and close it very many times, the time by which you reach the adequate oxygen concentration, you can get lost if you open and close it every time. But those are very helpful. You can consider using nose prongs or cannulae for direct, to increase oxygen administration. There is this recent interest in high flow nasal cannulae that allow for a higher oxygen levels to be administered with pretty much no discomfort. We've also used CPAP, which is this, spatial cap, which similarly increases oxygen concentration and works very nicely. Dogs tolerate it very well, and you see tail wagging there, and he's looking around. So that is some cheap options that you can consider if you don't have an oxygen kennel. It doesn't work very well in cats, I have to say. When we think about diuretic treatment, this is another paramount and treatment that we need to administer as quickly as we can, because it's a life-saving drug. And Ferozamide is the first-line treatment for acute CHF. You can give it IV or IM. You can give it as a bolus, or you can give it as a constant rate infusion. Depending on the use of boluses, you can give 1 to 2 mg per kg 1 to 3 hours. You can potentially go higher, but remember that there is always a risk of causing kidney damage if you go too far, because you decrease blood pressure, blood perfusion to the kidneys, and therefore it's also a big issue. And so I think sometimes being a little bit more cautious in terms of the amount given per bolus, you can probably give it more frequently rather than give a big chunk. Constant rate infusion is very handy sometimes, because we try to get the therapeutic range and we just keep it stable, which is different from the bolus, because you see that we have a peak and then we have a decrease, and therefore sometimes also if you're in a busy environment whereby you have to deal with multiple cases at a time, having a CRI can help you, because you don't need to worry about, okay, 1 hour is gone, I need to check, etc., etc. You start that, you of course monitor your patient, but you're not in the urge of giving it straight away because the infusion is going. And generally speaking, 0.5 mg per kg per hour is a really nice starting dose. If it's very severe, you can start 1 and then decrease it later on. Generally speaking, you would expect an improvement within 2-3 hours. They should already start to settle, and then within 4 to 6 hours if the CHF is very severe. If things don't improve, even after 4 or 6 hours, and you've given, a decent amount of furosemide, then you need to question your diagnosis or decide whether you need to go more aggressive. This is something pretty, obvious, but it sometimes can be tricky because you don't want these dogs to receive IV fluids. But then with CRI, you may need to add some fluid because you need to have a decent amount of fluids going into the body of our patient, of furosemide. But we need to avoid further volume overload. So one of the things that can be considered is using a hypertonic solution with furosemide CRI. And a study by Dr. Adding in JVC 2017 compared these two options, either 5% dextrose or a hypertonic saline. And they use this protocol, which is pretty handy and very helpful. So you basically try to get a 3.3 mg per kg of furosemide diluted to 2.2 mg per ml with either 1.5 ml per kg of dextrose, 5%, or 1 ml per kg of dextrose and 0.5 ml per kg of 7.2 hypertonic saline. And you mix all this together. In that protocol, they gave a 0.66 mg per kg furosemide IV bolus, but you can potentially give, standard furosemide bolus, 1 to 2 mg per kg, and then you start the CRI. And that protocol was using a defined start and end date, but you can potentially just start the infusion and then monitor the patient as soon as the patient has reached a decrease in resting respiratory rate. And patients with congestive heart failure tend to come in with very severe and high resting respiratory rate of up to 80. They may be panting, they may be so tachypnic. And then as soon as they settle at 40 or below 40, you can then try to wean them off the CRI and then switch to oral, which is probably what you aim in doing, even boluses rather than CRI. In inotropic support is important. Now we have pimobendan IV, which is very handy in acute congestive heart failure, mostly in dogs. It can work in cats as well. It's, however, expensive and not available in all countries. So if you don't have that, you can consider giving Peros, but then you need to be careful because you need your patient to be able to swallow without any risks for his safety or her safety. Dobutamine is another very important positive inotrope that can help clear congestive heart failure quicker if furosemide alone is not working, or if you know that you are dealing with a patient with severe or refractory CHF. You have to start continuous rate infusion because of the very short half-life. You can start low and then go higher if needed and titrate to effect. Generally speaking, this is reserved to patients that become hypotensive, but there are situations where they might not be that hypotensive, but they already received a decent amount of furosemide and they're not responding clinically as well, and so you can consider adding on dobutamine to help the heart work better and therefore clear the effusions quicker. Sometimes, above all when we are dealing with refractory cases, we can try to target left atrial pressures in order to decrease the afterload, to ease the cardiac work. Generally speaking, the best it's nitroprusside, which however is not always available or can be very expensive and can also require, well, not can but must require close blood pressure monitoring because of its severe hypertensive effect, because it's a vasodilator, is a very potent vasodilator. And so this can sometimes not be very practical in a setting whereby you can't monitor your patient the way you could in other places. So you could consider amlodipine in these situations, but I think you need an echo to prove that you have very increased left ventricular filling pressures, or you need some data to suggest that this patient has a refractory CHF. Is not something that I would put on a first CHF occurrence in a dog, for example, and in cats we don't tend to do that. Another alternative is nitroglycerin, which has been very frequently being applied in veterinary medicine as an ointment, but I think it's very difficult to determine the clinical efficacy. There is a small data on IV nitroglycerin, which has been used in people more frequently than we do in veterinary medicine, but it can be given as a constant rate infusion. But similar to nitroprusside, you need to be very careful about blood pressure monitoring, because they can become severely hypotensive, and that is not what we need to have on top of congestive heart failure. The good thing is, because they have short half-lives, both nitroprusside and nitroglycerin, you can adjust to the needs and stop it, and the effect will wean off quite quickly. When we think about the RAS system activation, above all, when we consider all the neurohormonal activation, we understand that it's a relatively slow system. So it's not a priority in the acute phase. But if we think about, a typical scenario of a dog coming in with a very mild CHF, owners refusing to hospitalize the dog, then you can consider starting it as long as blood pressure is fine and renal function is okay. And so you can consider, but then there is no rush. So you can also start it 5-7 days in CHF treatment at the first recheck visit. And you need ACE inhibitors and spironolactone. The dose of ACE inhibitors is very wide in terms of there is no strong evidence to support either one or the other. So the decision on how frequent and how much ACE inhibitor is needed is secondary at the moment, is following cardiologists' preferences rather than actual strong evidence to suggest that one dose is better than the other. And spironolactone is needed because you need to counteract the aldosterone escape that can occur with renin-angiotensin. It's not used for diuretic properties, which sometimes is still something out there, but it's a very weak diuretic. I think the only positive is that is a potassium sparing diuretic. It can make a difference in terms if you do aggressive diuresis to stop hypokalemia a little bit, but it's not the main reasons we are using. It's not the main reason we are using spironolactone in these days, but should be started as per the ACVIN guidelines after a CHF. So we have our patient, we've diagnosed CHF, we know what we want to target. What should we be monitoring in our patient that he's been hospitalized because of congestive heart failure? We need to monitor response to clinical treatment. So we need to monitor respiratory rate, which is actually very helpful. There are some situations whereby we have very anxious dogs that don't stop panting, and that is not because of congestive heart failure, it's because of their stress levels. So in some of these situations where you can't fully understand whether your dog is responding the way you want to diuretic, that you could repeat radiographs. And potentially you do, an initial one for your diagnosis, and then another one showing improvement prior to discharge. But then we need ECG monitoring in some of these patients if we also are very suspicious on arrhythmias going on. Blood pressure monitoring is important. Renal function is very important. And also electrolytes, because some of these dogs can have electrolyte derangements or can have very low potassium. They can also end up showing pH variation, so an alkalosis, metabolic alkalosis. And then we need to check how much we are dehydrating our patients with diuretics. So we need to check hematocrit, microhematocrit, and total proteins. And this can be done actually every 8 hours if the owners allow you to do that. Otherwise, at least once a day. If they're staying multiple days, it's probably reasonable in order to get an idea about progression and how they are dealing with the diuretic treatment that we're giving. And then we need a full echo once the patient is stable. And then once we have successfully managed our CHF patient and we send him home, what can we be monitoring later on after discharge? Generally speaking, it is reasonable to have a first recheck relatively early on, just to make sure that the CHF is under control, the clients are okay and compliant, and they're not having problems administering drugs. We check the kidney function is fine. And you can do a focus echo just to make sure that, you know, the heart has remodeled. The E-wave velocity can help us if it's, you know, mainly a degenerative mitral valve disease case that has decreased, so indicating lower left ventricular filling pressures, but also just checking that the LV diameters are the same, if not, they have reduced. And another very important thing is, once we discharge our patients, we should always try to suggest clients start measuring resting respiratory rate at home, because that is more accurate than in hospital, and because they can then become more familiar if they should have a relapse. And if they start measuring it and then you check on the clients and on the dog, of course, but if you check that the clients are becoming familiar with that at the first recheck appointments, that can save time in the long run. You can repeat thoracic radiographs then, you know, at the recheck visit, just to make sure that it's fine, and also to match the respiratory rate measured at home. But overall, it's, you know, the first recheck after the discharge is just to make sure that the dog or the cat is doing fine, and, you know, they are overall okay. They've improved their quality of life and they're not in CHF again, despite, you know, the initial treatment. What should we be suggesting thereafter? Well, you know, probably it would be reasonable to, you know, keep track of these patients every 3, possibly 6 months, 3 months, or 6 months, or when deterioration occurs. It always is difficult to suggest, you know, general guidelines because of, you know, the variability in CHF presentation, the variability of underlying disease causing the CHF, because we are thinking about, you know, dogs and cats, but, you know, they're not exactly the same, and even within dogs, some disease can be more aggressive than others. But what is sure is, if I had a patient that had a CHF event, a relapse in CHF can occur in the future, and the clients need to know that, because of course it's something that, you know, they've already been through, and they may go through this again and again. Sudden cardiac death can occur. It's variable. It depends on the underlying disease. If we think about DCM or arrhythmogenic right ventricular cardiomyopathy, those are diseases that are more likely associated with a sudden cardiac death than, you know, you would think of dogs with degenerative mitral valve disease. However, if you think about degenerative mitral valve disease, atrial tear causing fatal hemorrhage is a possibility in advanced diseases, and so it's not it's not common, but it's not impossible either. And if we have cats, we always have to mention to the clients about the possibility of aortic thromboembolism, and therefore if we have a cat with CHF, we should also add antiplatelet treatment such as clopidogrel to prevent or try to decrease the risk of aortic thromboembolism. And as I said, RR, respiratory rate monitoring, so RR, is helpful to target visits when needed. If you have a compliant client that is, that has become familiar with monitoring respiratory rate at home, and you have a dog or a cat that has already, had a CHF episodes, then you could potentially say, contact me when the respiratory rate increases. Sometimes this is not feasible for many reasons, and therefore it's better to schedule some rechecks. But if you have the right clients with the right dog and they are compliant, then that is also another options that you could offer. But it's all depends on the ability and the possibility of these clients to spot very early changes. Once a dog or a cat goes into congestive heart failure, there is, a big change in survival, because we know that we are dealing with a heart that is, that has failed in many sense, and we are helping, but this dog or cat will likely die of heart-related issues most of the time. And clients will ask, what's the average survival, or what's the prognosis, what's the outlook look like? And I think that is also very difficult questions to answer. And it's, we're talking very generally, and so it's very difficult. But in general, I would probably say that could be the average survival is around 6 to 12 months. And it's very variable, so we need to remember that when providing numbers, we are talking about a generalized population. Some disease conditions can be associated with a shorter survival, some others may have a longer survival. So I think probably 6 to 12 months is a reasonable overall view for all of these cases. But some dogs may do well for more than a year. Some cats may have transient myocardial thickening, which is, a sudden acute thickening of the LV wall associated with congestive heart failure, but they will then, we don't know 100% what's the underlying cause of that, but some of these cats will return to normal without any needs for diuretic, and therefore their survival is likely to be much, much better than 6-12 months. But in general, if you have a dog that truly has heart disease progressing into congestive heart failure, the survival will be shorter. And you can't tell for sure 100% who is going to live longer, who is going to live less. And as such, these average values are just a guidance, but are not, something to very thoroughly say it will be this way. And I think the most important thing sometimes to clients is not only the expected survival, which of course they will want to know, but is the quality of life. And I think that is very important. We want to have our patients enjoy a good quality of life. I haven't even discussed, surgery for mitral valve disease, for example, which indeed will change survival. But, there are many variants in this, but will need to be, it's just a general number just to get an idea to the clients what to expect next. But I think quality of life, treatment and compliance and following these patients is probably what we want to do, and continue monitoring these patients. So I hope you enjoyed this 45 minutes seminar on CHF management, and I'm happy to take any questions.
Hello. I hope you found this discussion informative enough, as you said, and as you saw, there were many things that I was really keen on discussing with you, and I hope I kept it very practical. Now we have some questions that were submitted prior to the webinar, so I'm going to just briefly talk through these, but feel free to jump in and ask other questions if you have more that I'm not answering, and if you have more questions about, because I understand it's a very broad topic. So I think one of the things that I didn't have enough time to discuss is what shall we be doing differently when we have a dog or a cat that shows congestive heart failure, but is also azotemic, or we manage the CHF very well, the dog or the cat is doing better, but renal function is not great. So I think the first thing is to try to work out what the reason for this azotemia is, because I think it is reasonable to expect some level of, stress on our kidneys, because we are giving, diuretic support, and some of these dogs or cats can become hypertensive, they can have decreased renal perfusion, and therefore the kidneys will suffer out of that as well. So we may have a pre-renal component on top of a renal component. And sometimes the renal component can be unmasked only when we ask our kidney to work more. And therefore, I think it is very difficult sometimes to say what is the level that we use. I think in general, we wouldn't want our patient to become severely azotemic. And I think that is something that it is a bit difficult to determine as a general guideline. In general, if we think about acute kidney injury, there are different definitions, but if we were to apply some of the human-related guidelines, they talk about an increase of 0.03 milligrams per deciliter of creatinine, or a greater than 20% creatinine increase. And I think that is something that sometimes we do see that in our CHF patients, but our patients are stable. It is important to underline that we need to know how dehydrated our patients are, because if I have a creatinine that is increased, but I also have a very dehydrated patient, because in a way I overzealously dehydrated with furosemide, I think some of these values will decrease over time. And we have to remember that acute congestive heart failure is not, we're not using the same diuretic doses for the acute versus chronic phase. And that is why sometimes I think most of the cases that I've managed with severe azotemia were situations where it wasn't clear or we overzealously dehydrated our patients rather than and waited a little bit longer on a CRI, for example, furosemide CRI or furosemide boluses, or those typical situations whereby you have a patient who given a oral diuretic dose. The client sometimes takes longer to come back at the rechecks, and that's when you find severe azotemia. And I think in those situations, it depends also on the severity of the azotemia and the clinical signs. I think we need to be aware of that. Of course, I'm not happy if I see a dog with creatinine values 10, 20% above normality ranges. But if the dog is happy, is eating, he's not showing clinical signs, I think you need to adjust the diuretic. Probably, if, for example, was receiving 3-4 mg per kg Q12 hours because it's a refractory case, then you just decrease a little bit lower, and that will do, in the sense of probably decreasing 50% keeping the client very closely monitoring respiratory rate, because that's the risk. And sometimes they do settle. I wouldn't start ACE inhibitors in this situation. I would wait until the azotemia is better. And that is one of the other reasons that in the acute congestive heart failure cases that are severe, I wouldn't start benazepril or enalapril or other ACE inhibitors in the acute phase, because I really want to get that dog, dry in a way, to dry those lungs, make sure that they are happy in the CHF management, start at lower or the lowest effective diuretic dose, which is a great sentence, but sometimes is more difficult to find. And then check renal function, make sure that if there is a mild increase, it's not super elevated, and then start benazepril or enalapril, or whichever ACE inhibitors you prefer. There are situations which require more aggressive control, which is the situations whereby you have dogs that come to you that they are weak, lethargic, they're not really keen on eating, and then you get creatinine values, very much higher creatinine values. I can refer to milligrams per deciliters, but let's say around 4 milligrams per deciliters, that is too high. And therefore you need to adjust. If it's a chronic case, if it's a chronic dog, and you sometimes see that these hearts are really volume depleted, so they had this massive left atrium in the beginning, and then you recheck them and it's pretty smaller, much smaller than before. It's not that we are doing a great job, because probably they are too over dehydrated. And in that situations, I think you could potentially stop and discontinue furosemide for a couple of days, give supportive treatment, which doesn't include IV fluids. I would avoid them if possible, but you can give, Cerenia, encourage eating, encourage drinking, and then recheck them. But you need very close monitoring in these patients. Literally having them coming in, not every day, but every day or every couple of days. The client needs to be very proactive in terms of monitoring respiratory rate. But just to further underline this, if there is a mild increase in creatinine values and the dog or the cat is not showing clear clinical signs of azotemia being clinically relevant, I wouldn't stress too much. Okay, you can try to adjust, but remember, the big issue with this is if you go too low on furosemide, then the risk is that they have a relapse in CHF, and then you have to become aggressive again, more aggressive than chronic CHF management, and that can become an extra stress for our kidneys. So the ideal is, you go with the acute phase. You don't have to be, super aggressive in terms of boluses of 4, 5, 6 mg per kg. I think it's better to go a lower but more constant rate at the very beginning to try to avoid kidney damage. Make sure that they are stable, wean them off the IV or IM dosing of furosemide, switching them to oral, and then try to find the right oral dose at home. This can be relatively easy if you have a first case of CHF. If you have refractory CHF, it can be challenging. It's not easy. And I haven't fully discussed furosemide and furosemide and when to switch, when to start, but furosemide is a potent diuretic. It's much more potent than furosemide. Furosemide has a lower oral absorption, and therefore you can have dogs that respond very well to the 2 mg per kg per off, and others that they don't. You need to increase furosemide dosing. Furosemide, on the other side, is more potent and has a much better absorption. Therefore, there is a more stable reaction to that in every patient. There is less individual variation. However, it's much more potent. So you need to be careful, because in those situations, you could crack the kidneys, in a very jargon term, much easier. It's much easier to crack the kidneys with a wrong dose of furosemide. And it's sometimes very difficult when you have refractory cases to decide the equivalent of furosemide to furosemide. I think there are many ways of doing this. I don't tend to offer furosemide as a first option for CHF for these reasons, because there, the chances of finding the right dosing after you manage the acute CHF can be difficult. And if you aren't sure 100% the dog is in congestive heart failure, you risk to damage the kidneys pretty much more than by using furosemide. It's always a matter of how much you give, because of course you can damage the kidneys just by giving furosemide. But I think furosemide and other diuretics in the refractory cases, I haven't discussed thiazide diuretics. There wasn't much time to delve into those refractory cases that can be very frustrating, very challenging. It can be challenging for us, and for the clients, because we are asking the clients to, give many pills. Some dogs may end up being a little bit more inappetent, a bit weak. It's difficult. But, I think furosemide is a good option when you have to switch. I would generally first give it a go with furosemide. And as I said, because there is some individual variation, some dogs may respond well, some others may require increasing doses of furosemide. And those are the cases where I recommend a switch. Some people like to start 0.1 mg per kg once a day. But I think that is applicable only if you have very mild CHF, and if you don't have a relapse. Because I use this drug more in refractory cases, 0.1 mg per kg once a day is not going to make a big change. And so I generally calculate around 0.2 mg per kg and then average the result to the lower dose and then go and administer it. But I tend to go twice a day rather than once a day. It's an off-label use, but I'm dealing with refractory cases. Okay, so for first line CHF, you should probably go lower. And you can start higher and then decrease it. Like, let's say if you're managing them from home management of CHF, you can start 0.2 for 2-3 days and then decrease to 0.1. But as I said, I think it's more difficult because you're managing them from home. You can't really see 100% what's going on with the kidneys on every day. I think it's a bit tricky. It can be helpful in cats, but remember that cats may require lower doses. I've managed a couple, but those were very severe refractory cases. And I've started 0.05 mg per kg once a day. Furosemide can work nicely, though, on right-sided congestive heart failure because of these intestinal absorption, oral absorption, that is much better, and that can help more. But as I said, I'd rather start, maybe in the hospital with IV IM furosemide, stabilize my patients, and then, if they don't respond to furosemide, and you don't need, weeks to determine if they're not responding. If you need close monitoring, and you check on them 4 or 5 days after CHF, and you still see that you're not fully happy with the result, you increase furosemide, you recheck on them 2-3 days later, it's not working. Now it's time to change. That happens, and what changes and what is, I think, a good strategy is close monitoring in these patients that don't tend to respond very well, to what we can consider a standard CHF treatment. But as I said, I think kidney function, what is important is to try to work out, is it pre-renal, is it renal, Is it because, you know, I've been aggressive on the acute phase? Because you should expect an increase in kidney values at the very beginning, but it should normalize, and the dog or the cat shouldn't be clinical. If they're not clinical and they're eating well, drinking loads, which means that the diuretic effect is there, and they're not vomiting, they're not lethargic, then that's great. That's what we want. And I wouldn't be too concerned. I would delay ACE inhibitors just to make sure that, you know, we allow the kidneys to do their job. It's not paramount, as I said, to start ACE inhibitors straight away. And I think that is the main point. I think the clinical picture is what we look for, and that, you know, if we have that, that's a concern, and obviously we need to be more aggressive in terms of, and more proactive in treating it. But you can always try to adjust diuretic dosing to try to see if a lower effective dose is enough to keep them out of CHF. And I think the question is best ACE inhibitor we can use in CHF. As I said, I think you're not in a hurry. I think there are a lot of preferences within cardiologists. I tend to use benazepril because I also prefer to use a lower dose to start with, and then I can always increase it later on. But as I said, I think there are different approaches. There is not one that is, you know, fully recognized as better. And if you live in countries where the human one is better in terms of cheap options, and it's not an off-label, not a fully off-label, and there are some cost concerns in the client managing, I think you should do and choose whichever fits your client's needs best. Obviously, if there is a veterinary formulated drug, that should be the ones that we use. But if there are situations whereby finances, compliances, and supplies are an issue, you can, you know, choose the best options for your, you know, dog or cat. In cats, I don't think there is any evidence in terms of survival that ACE inhibitors will do the difference. We know that the RAS system is activated in cats receiving furosemide, so theoretically that should be added. But cats, and I will just like go on with another question about how would you start. Let me just find the question. There was a question about cats, about when, you know, how would you do that with cats? Because I think one of the things that we have to remember is cats are not dogs, are not small dogs, and we all know that, right? And I think when it comes to treating cats with congestive heart failure, the big issue is making sure they receive the drugs. And as such, sometimes, you know, having the client discharging the patient with a long list of medication, the clients will look at you and like, oh my God, what I'm going to do? How am I supposed to have all these drugs in my cat? And my cat, you know, spitting all the pills, it can become a challenge. So I'd rather go with a slow approach rather than pushing all these drugs in. And I think that is something that is important, above all in cats, but I think it would probably work in some dogs. So I think the priority is diuretic. The second priority in dogs is pimobendan, and then comes, you know, neurohormonal activation for chronic management. So I think if you suspect that your client is not going to be fully compliant, just one little step at a time will probably make a difference. And in cats is the same. Diuretic first line, clopidogrel second line, and then you add on, you know. So I think this is something that is very helpful because it's not overwhelming the patient. You probably make closer checks and then add on and say, okay, how are you dealing with, you know, giving fluffy these pills? Is it okay? Okay, we need to add another one. Shall we do this way? So I think that sometimes changes the client's perspective. Of course, you have to prepare them saying, you know, these are unfortunately life-saving treatments. These are lifelong treatments. We need to, you know, we want to improve your dog, your cat's quality of life. And sometimes it can become very daunting to clients to say, okay, I have 4 medications to give to my dog. How can I do this? How can I do that? And they need to work out a routine and some strategies. So don't rush them. But of course, you know, life-saving drugs first, and then all the other ones second. So there is another question about Ferozamide, good option for cats. I hope I've answered partially to that. As I said, I think Ferozamide is very potent, and it's a good option in terms of the semi-LNDA or SID dosing, so once a day. But be careful because it's very potent and you can have some undesired effects. So you need to, you know, adjust the dose and start very low. So I wouldn't push that as a first-line treatment unless, as I said, you have a very, you know, difficult situations and you just have to decide what's best for your patient, but start very low, like 0.05 is probably the starting dose in cats. So I think how to manage CHF in cats, when to add extra medications, and how I hope I've tackled that questions. There was another questions about how to best differentiate cardiac problems other than using signs and symptoms. I suppose this was, how can I tell this dog has, let's say, degenerative mitral valve disease versus DCM, so versus dilated cardiomyopathy phenotype, other than signs and symptoms. And I think that is a very difficult questions to answer and to try to answer ourselves. I think sometimes signalement can help, but it can be misleading. So in general, if you expect, you know, a small breed dog with radiographic, for example, signs of a big left atrium, a big left ventricle, then it's more likely to be degenerative mitral valve disease. If you have a large breed dog, you would probably expect a DCM phenotype being top on the list. But I think, you know, it's very difficult to rely on that. I think in general, because we're talking about acute CHF and chronic CHF in dogs, there is not much difference as much as if we think there is degenerative mitral valve disease or DCM. They both need inotropic support, they both need furosemide administration, they both need RAS activation system inhibition. So I don't think that makes a big difference in terms of how you deal with that. I think the most important thing is when you have right-sided congestive heart failure, and so you have a patient with ascites, make sure they don't have cardiac tamponade, because that is the one contraindication to furosemide administration. And that is heart failure in a way, right? It's forward failure, and backward failure at the same time. But, you know, that is a very strong contraindication to diuretics. So if you suspect cardiac tamponade, because the dog has, you know, pulsus paradoxus, and the dog has a big belly, and you don't hear murmurs, let's say, and you put an ultrasound probe on the heart, make sure they're not tamponade. They don't have cardiac tamponade, because in that situation, you need to do an emergency pericardiocentesis. Other than that, in cats, similarly, I guess one of the reasons and one of the rationales that you can, you know, try to get in terms of how do you manage a cat with respiratory distress that has refusions or pulmonary edema and has, you know, all different kinds of cardiomyopathies. I think in the acute phase, there is not much difference in terms of diuretic treatment. The use of pimobendan, which has been asked in cats, it's a bit more difficult to be answered in a general way, because in the acute phase, I think the only concern you may have in a cat by giving pimobendan in the acute phase is the only thing that could cause, and it has been reported, but in very few cases, is transient hypotension. If you have severe obstructive cardiomyopathy, so if you have a severe LVOT obstruction, which by severe I mean severe gradient, so a high velocity LVOT flow, because of the obstruction caused by the systolic anterior motion of the mitral valve, it has been reported transient hypotension, because you are squeezing your heart harder, and therefore the obstruction will be greater. But that has been referred to a minority of cases. In the vast majority of cases, it is safe to give pimobendan in the acute phase. And in the chronic long-term management, there has been a study that did not show greater survival if you were to look at the general population of the cats analyzed there. However, if you had cats without the obstructive component, so if you had cats without a loud murmur, and that's how I generally tend to do when I'm in clinical practice. So if I hear a loud murmur, and by loud, I mean 3, 4 out of 6, and the cat, is not showing a severe CHF, then I wouldn't probably push for that until I do an echo. So I wouldn't push for pimobendan in the acute phase. If I have a cat that is, has severe CHF and has no or very soft murmur, I would generally go for it. And because when you don't have that obstructive component, in that subpopulation of cats, the analysis did show that pimobendan was associated with a greater survival in the long term. So I started in the acute phase and then I continue it. Sometimes it's difficult to know, where to go, because, as I said, there are places and centers and cardiology specialists who would recommend pimobendan in all cats with CHF. And I don't think it's, wrong doing that way, but I think on the basis of the data that we have, it's an extra pill we are going to give to this cat. And if we go back to the client compliance, it's 2 pills a day we are adding. And if there is no survival benefit from that data, I think it can be challenging and daunting to our clients. As I said, if you have a cat that receives all the meds in the world without any problem, which they do exist, but they are a little bit of a unicorn, you can give it. But I think what I generally tend to do is this way. Okay, can I hear a very loud murmur? So do I suspect there is an obstructive component that is important in that disease process? I may not be pushing for that in the first place. I may evaluate that and reevaluate that with an echo, with follow-ups, knowing that the clients can give that. Well, then you can discuss that. If there's no big murmur and they are in an advanced cardiomyopathy, therefore systolic function will be, depressed, then you can go. I mean, not you can go, but that's what I suggest to start with, even in the acute phase. Let's see if I have other questions on top of that, and then I'm going to look at all the ones in the chat because I see that there were some popping up. So another question was, is a positive proBNP result enough to start medications in a dog with a heart murmur but no heart symptoms? And I think that is a bit of a difficult question to answer. So I think the question is, pimobendan, I wouldn't rely only on one test to say we need to start pimobendan. I think I've discussed that on heart murmurs as well. So you're more than welcome to have another look at that. And I'm more than happy to answer further if needed. I think if you're concerned that you have a dog with clinical signs of respiratory distress, you need to have clinical and diagnostic correlation. So you need to be sure that that dog has a murmur, but also is tachypneic because of heart disease. And if that is the case, then yes, let's go with pimavanserin. And the ProBNP can tell you the chances of being in heart failure, but I wouldn't rely only on that as well, if that makes sense. I need more than just one data to say. It's also safety net, isn't it? Just, you know, I may get a wrong answer if I just like rely on one, but if I rely on the clinical signs and diagnostic findings, then it's safer for me to say, okay, it's more likely to be this way, I can go on. And, you know, at the end of the day, we are giving medications. We need to make sure that the medications, the cost and safety benefits are balanced. We want to be sure that we are dealing with them, and we're not making them spend money, that is not required, that they can spend on something else that may be more useful. But if it's needed, then, you know, let's crack on. Let me just see if there are other questions. So there is another very, very nice question that, you know, per se would be just like a 30 minutes webinar alone, which is what are the echocardiographic parameters in, I think, congestive heart failure in dogs and cats that you would be looking for. And I think it depends on the, how to say, on the level of the question, on the level, and what are you going to use, what use are you going to make of them? So as I said, so I think, for example, if you have a dog in respiratory distress, I think the question is this a question about survival and long-term prognosis, or is it about what should I be looking in the acute phase? So I would just go to answer your acute phase, because in the long term, I think there are plenty of things, very interesting things that we can discuss. But it's, you know, it's a 30-minute webinar alone. But I think what is helpful, and I think that has been changing in the past years, and I think that's great, because it's something that will empower you as clinicians to make your decisions, is the focus ultrasound. So you scan the lungs to check for B lines, effusions, etc. And there are people that are probably much better than me in this explaining this to you. But I think things that we need to look from the focus on the heart side is left atrial size and contractility. I think those are the two main things that we want to look, and effusions. I will probably add effusions. Effusions in terms of pericardial effusions, cardiac tamponage. Those are important because, as I said, in those situations, no Ferozamide, but pericarditis increases. Left atrial size is important because I think if you have a big left atrium, whichever the underlying disease is, or a big right atrium, if you think about, the typical bulldog with arrhythmogenic right ventricular cardiomyopathy, those are hints that there are going to be increased left ventricular filling pressures, and therefore congestive heart failure is going to be likely. And contractility, because contractility can help us saying, okay, there is poor contractility there, and I need to act on that as well because it's part of the treatment. So I have a big dog, I have poor contractility, DCM phenotype. Let's start treating with PIMO and dobutamine maybe. I have a small breed dog. I see a very thickened mitral valve, and I also see poor contractility. That is a poor prognostic factor. We need to be aggressive in terms of inotropic support. So I think those are the very basic three things that are very informative in the acute phase. If we think long term, I'm afraid I'm not sure I can answer all these questions. It's a very good topic though to discuss in the future. I think, which parameters do you consider when a dog in CHF needs medical therapy? I hope I've answered these questions already in the seminar, but please Let me know if you need more information on that. But as I said, monitoring is important in these patients. It's a very, how to say, it's a very ever-changing situations. We want to make our clients, but also our patients, most importantly, feel comfortable, settle down as quick as possible. But sometimes we don't want to be too aggressive, because then, you know, we have to deal with, you know, for example, severe azotemia, etc., etc. So I think you have to balance, and it's not really easy, I have to say. I've been there, and I think everyone has been there, and like, should I be more aggressive? Should I be less aggressive? What should I be doing? And I think it's the monitoring. Every patient is in a way a little bit different. What I gave you is guidelines, and then you have to adjust to the needs. There is another very good questions about when to use atenolol. I think there is another ad about this webinar, is that I purposely didn't speak about arrhythmia management on top of congestive heart failure, because that would have opened to another 30 minutes discussion. I think in general, most of the arrhythmias that we do see in CHF are partially pushed or exacerbated by the CHF. So in general, treat CHF first and then reassess the arrhythmia. That is true for atrial fibrillation. And if you see occasional ventricular premature complexes, this is the case where you're like, okay, I know they're there. I'm not forgetting about them, but I need first to clear, you know, the CHF. In situations where you see runs of VTAC, and where by VTAC, I mean ventricular rhythms that are fast and sustained. So we're talking about heart rates greater than 180s, then you would probably need to be more proactive in the acute phase. Those are the minority of the situations, and that carries a little bit of a higher risk of sudden death, even in the hospital. And I would probably consider lidocaine boluses to start with. CRI, lidocaine boluses are 2 mg per kg in dogs. In cats, I would probably start at 0.5. And then you can give CRI lidocaine and then switch to oral. But as I said, those are the minority. The majority of cases are, you know, occasional VPCs, or atrial fibrillation. Try to treat the CHF and then reassess, because some of these arrhythmias will improve as you are dealing with CHF. Okay, so I think that is the general rule. Atenolol, I think the question is, in which situations do we use atenolol? I don't think in the acute phase we ever use atenolol. I think in cats, the problem with atenolol is if we are dealing with a failing heart and we give atenolol is a beta blocker, is going to decrease systolic function, and therefore the risk of worsening CHF is there. So once CHF is there, I don't tend to use atenolol for the purpose of, for example, HOCUN, so systolic anterior motion causing left ventricular atrial obstruction. I don't tend to use it. I tend to wean them off, because the effect that I'm expecting with atenolol is going to be is going to not to be as much effective once they are in CHF, because we have a failing heart. But that is my personal preference, and there are some reasons behind that. But in the acute phase, I wouldn't use atenolol. If you use atenolol for arrhythmia purposes, then that is another story. Then I have another question about when to add an ACE inhibitor versus pimobendan, and I hope I've answered that question as well. So in general, as I said, ACE inhibitors are not the priority in the acute phase. The reasoning is ACE inhibitors, the pimobendan in clinical phase is a totally different story. And I think it's just too much to add, but as I said, in the acute phase or in CHF cases, you do need to have both, and you need also something else like Ferozamide and spironolactone. There is another question that is, would be opening another great discussion, which is what left ventricular thickness cutoff do you use in cats? And I think that is again, very difficult. The short answer is 6 millimeters a reasonable cutoff? it is. Are there situations where you would use different cutoff? Possibly. The ACVIN guidelines are very broad in this sense, but they say, you need to evaluate the breed, the weight. Sometimes probably 5.5 is already telling us that there is something not 100% normal in most of 3 to 4 kilo cats. But I don't think we have that strong evidence to say, we have some problems with measurements, etc., etc. So the short answer is 6 millimeters a good cutoff? I would probably say yes. In the vast majority of cases, that is what I would rely on. But you need to, assess systolic function, geometric, the morphology of the heart, the LA size. There are many other things that together with that cutoff can help us say it's very likely that we're dealing with a cardiomyopathy. Sorry, but that topic is I'm very fond of that topic too. And the use of in-house NT-proBNP testing in cats, I hope I've discussed that in the heart murmur webinar. So in general, I think that can be helpful if you have a cat with respiratory distress. The performance of the test is great. So definitely is a good one. But remember that cats with murmurs can have a severe elevation NT-proBNP, and that is not strongly related with outcome or clinical signs. So if you have a cat that doesn't have murmurs but has clinical signs of respiratory distress, NT-proBNP testing, the SNAP test, is great. And you can use it also on effusions to help you define. If you have a murmur, it's a bit more difficult. You need to find probably evidence of left atrial size, enlargement alongside with NT-proBNP, positive NT-proBNP testing. But in general, if it's a positive one and you have a clinical signs of congestive heart failure and CHF and left-sided CHF mainly, then that works very nicely. Let's move on to the additional questions that we have on the chat, because there are many ones. So one question was, can we replace furosemide with furosemide? And can we combine pimobendan with ACE inhibitors? So as I said, I think furosemide with furosemide, I hope I've answered your questions already, but feel free to chat again to let me know if you need more information. And pimobendan with ACE inhibitors can be combined in the long term. I think the only downside of this, because I know that there are some drugs that offer this combined pimobendan and ACE inhibitors together. I think the only downside of this is if you're dealing with a dog with azotemia, as we were discussing before, severe azotemia, I would stop linezolid. And because the client already has this drug together with something else, that's a problem. You need to ask them, okay, can you please go and buy another? And I think that's not very handy, in my opinion. But I think, you can give it, but remember, you need also to ask spironolactone. So yes, you're saving on one drug, but then you will still need to have something else. So it will still be 3 drugs at the very least. Well, not 3 drugs, but 3 pills at the very least. So I'm not sure it's very, you earn that much. But yes, indeed, you could consider that. Azithromycin can be used. I think the only problem with ACP is that you can still cause a little bit of vasodilation and it's not reversible. And I think that is a bit of, not a concern, but it's something that you don't want to cause hypertension because you're using that sedation. I think butorphanol in that sense is much safer, but you can give it as MIDGE if needed, if you have, a very stressed patient. But you need to monitor blood pressure very carefully. Okay, so the other question that I have here is, when you start furosemide for a CHF, is it for a lifetime or a tapering dose? I think there is only one exception to this rule, and it's transient myocardial thickening, as I briefly mentioned, because in these situations, it's an acute damage of the myocardium. And it has been shown that the vast majority of these cats that then a normalization of the echocardiographic changes did not require furosemide full lifelong, because it was an acute situation that led to CHF. But in the vast majority of situations, if I have a failing heart, then furosemide will be needed long-term, forever. You can, as I said, try to taper it down to the least effective dosing. You have to be careful though, because then if you taper it too low, then you need to increase it further. So it's very difficult to find the right ones. I don't tend to go lower than 0.5 twice daily. And I think giving it once daily, it's a bit challenging because of the pharmacodynamic of the drug, because I don't think it's very effective in 24 at one single dosing. So I'd rather go lower twice rather than once daily. But then, you know, you may have to find the tweaks. But I think once the CHF is there, it's there. And you can help by decreasing the effective dose. But most of the times, I don't think less than 1 mg per kg twice daily is effective. I think, as I said, there are some situations where, for example, the dog or the cat has been pushed into heart failure, for example, by IV fluids administration. So if that is the case, then you may be able to stop it or to decrease it very, very, very low. But most of the times it's lifelong. So there is another question. So I would probably still, sorry, I was reading the question without, I was already answering the questions without reading it. So there is a question about, should benazepril be given if the cat is azotemic? I think the question is why the cat is azotemic in the first place. If we suspect that the azotemia is because of our treatment, so if it's pre-renal, then I wouldn't give it. If we suspect that there is kidney damage and there is proteinuria on top of that, so that has been identified before, then you can potentially go on and give it. But I think the question is what we suspect, better said, what we suspect the reason of azotemia, of the cause of azotemia is in the first place. There is another questions about, in the ACVIM classification, they say we do not give pimobendan stage B1, it's from stage B2. But for example, if we have a Cavalier King Charles Spaniel, so a dog which very, is known to be predisposed to heart disease with stage B1, and we know that he will go automatically into B2, can we give it stage B1 or we have to wait for stage B2? So I think the question, so it's very difficult, isn't it? So I don't think we already have that information that tells us which dogs in B1 is going to become a B2. And we know that many dogs that are B1 may go on being a B1 for such a long time that, the cost of giving a medication at an early stage is probably not justified in terms of the client's expectation. Sometimes it's probably best to invest that money on monitoring rather than giving it early. And I think that is something very difficult, isn't it? We wish we could know straight away, okay, so this dog is at risk of becoming a B2. And I think what can help us predicting who is going to progress is by monitoring. I think there are some evidence showing that if the VHS continues to grow over time, if the left ventricular internal dimensions and the left atrium starts to increase, then those are indicators that there can be a progression. The rate of progression, however, cannot be, fully predicted on the basis of a single echo. I think we need to have different snapshots. So I will probably go alongside this way, because then, we may have clients that are very proactive in starting medications early, and that is not a big deal in terms of money and effort. But there are other situations whereby, clients were like, oh, I wish I'd known, I couldn't, I don't need that at that stage. So I think it is our responsibility as clinicians to try to find the right way of following these patients. And I think, follow-ups And you can potentially go every 6 months. And then if there is a progression, having it earlier on, so every 4 months, and go on straight away. So, I mean, I hope I have answered all your questions. I do hope you found it helpful. I do hope, you know, it has a clinical impact on your everyday practice, but do feel free to message us and to contact us if you need additional, you know, if you have additional questions on this topic. And I thank you all for your time to listen and for your engagement. That was great. And I'm here to help you should you need me. Okay, have a great day or evening and speak to you soon at some point. Have a good day. Bye.